Well, welcome everybody. Welcome to the Neurology Video Journal Club. I am Alan Salgado. I am a neuromuscular neurologist and clinical assistant professor at the University of Michigan. I will be speaking with a colleague of mine, Dr. Savannah Quigley, who is one of our neuromuscular fellows and soon to be faculty here at the University of Michigan. And we will be discussing a systematic review and meta-analysis called Clinical Characteristics Associated with Secondary Generalization in Patients with Ocular Myasthenia Gravis. I will let Dr. Quigley go ahead and take it away and start our discussion.
Great. Thanks, Alan. As Alan said, this is a study, a systematic review, and their main purpose of this study was to determine the proportion and clinical characteristics of patients with ocular myasthenia gravis that then convert later to have secondary generalized myasthenia gravis. To get into a little bit of how they did this, I'll take us to our first slide. So they had two independent reviewers search four databases, and they had search terms of basically all studies, randomized control trials, prospective, observational, and retrospective studies. And through these databases, as you can see, they identified 1,873 records. About 1,000 of those were duplicates, and so they actually ended up screening about 820 records with abstracts and titles, and that brought them down to about 102 records, which were read in totality. 71 of those were excluded for various reasons, including being pediatric population or congenital myasthenia. This study only looked at adult patients. Really, if the study didn't kind of help to answer their question of ocular myasthenia converting into secondary generalized myasthenia. And that left them with about 31 studies with around 4,000 patients that they got data from.
So I also want to kind of discuss the search strategy they used, right? They used several different databases, right? They used the Embase, Central, Medline, Web of Science. I think when it comes to systematic reviews, you want to try to find all data that's out there that is representative to be able to give us a sense of the characteristics that lead to generalization. So certainly the minimum in terms of including those electronic databases were included. You want to try to also include non-published data if possible. There wasn't any comment on personal files of experts, abstracts, conference proceedings as well, but if anything, those were included in their search strategy.
And I think one nice thing they did sort of in that vein is search all of the references for every article that they did look at to see if there were additional articles that didn't pop up in their database. So that was one nice way to kind of get additional articles. But again, those would be published, like you mentioned. They also used a pretty standardized approach to extract data from each of these articles. So they used kind of a set framework, extracted certain data principles, including, sex, age, acetylcholine receptor antibody status, et cetera, to make sure they got as standardized data from each of these 31 papers as they possibly could. What they came up with was this kind of main table. This was sort of their summary table in the paper of all 31 papers that they looked at to come up with this meta-analysis. And one thing you can see is that, while they searched for randomized control trials and prospective trials, 30 of the 31 were observational or retrospective trials, just kind of speaking to the fact that randomized control trials haven't been done to answer this question before. There was one prospective chart review they were able to glean kind of with 37 patients, kind of fifth up from the bottom there.
And in assessing these, kind of looking through these studies, there's a lot of things that you can kind of glean from. But one thing that also comes to mind when it comes to including these studies is trying to reduce the amount of bias that are included in the studies that are involved. And now it's not listed in this table, but if you look at the supplementary material, there is a summary of the risk of bias of these studies that were published in the supplementary table, and they use the Ottawa-Newcastle scale, which is a tool used to essentially assess the quality of non-randomized studies included in a review like this. And so each study is usually judged on 8 items, categorized in 3 groups. One including a selection of study groups, 2 comparability of the groups, and 3 ascertainment of either exposure or outcome of interest. And in that table, they had kind of assigned stars, and all the studies except for one were 7 out of 9 stars, which were high on that scale. One was 8 out of 9 stars. So of all the studies they included, that's at least how they assessed this list of studies within this table. But looking at kind of just kind of doing an eyeball test and looking at it, you see there's kind of a wide variability in the studies. Certainly they included a lot of different countries. I think I can't recall if I look here, I think it was 31 countries that were involved. I'm sorry, 31 studies. And then there was quite a few countries. The United States had 7, China had 3, UK had 3, Thailand had 3, South Korea and Italy had 2 each. And then the sample size, certainly ranged from anywhere from 34 to 946, and the mean age from 40 to 83. So certainly wide variety there just by looking at this table. Certainly also big difference between the mean duration of follow-up as well.
Yeah, I think there was definitely, a wide range of studies, like you said, different languages, different countries. And some of the other things was just the way the data was reported, it seems like, in each paper. So you can see some papers had only included antibody positive patients. Other papers included both seropositive and seronegative patients. And then there were kind of different definitions. I think one important thing to keep in mind as we're looking at this paper is how do we define, what is ocular myasthenia gravis? Because certainly people with generalized myasthenia gravis can present with ocular symptoms first. And so there was a lot of variety, it seems like, with how that was defined in these papers, anywhere from 1 month of ocular symptoms before bulbar or other generalized symptoms to 2 years. And I don't know if there's a standardized definition of what ocular myasthenia is in terms of the time course of symptoms before generalization.
Yeah. And another thing to also take into account by looking at the table is that the lowest age that was recorded here, at least that were involved in these studies, was age 40. And we know that there are 2 big groups of patients when it comes to age that develop myasthenia gravis, certainly younger individuals in their 20s and 30s, and then it kind of drops off thereafter. And then there's a bump later in life in 50s, 60s that develop MG. So certainly the inclusion of these studies kind of doesn't include the folks that are much younger as well than age 40.
Right, or pediatric patients with myasthenia. This paper wasn't really looking at whether they had any different outcomes and who generalized or when they generalized. I think one thing this paper doesn't comment on, just given the heterogeneity of the studies they looked at, is time to generalization. So as we'll see as we get into the results, they sort of focused on the proportion of patients that do generalize and perhaps some risk factors for who might generalize, but not necessarily time course to generalization, which obviously would be different patient to patient, but was not able to be kind of extracted given the difference between the study data. And I think some other things to just highlight are the different, I think you already mentioned this, Alan, actually, but the different follow-up duration in the studies definitely could have an impact on the results as well. Because if you only follow someone, some of these are 9-month follow-up duration, people could certainly generalize after that versus the one on top, 103 months. And so kind of might impact who you're capturing in terms of generalization as well.
Yeah. So, I think this highlights, right, the clinical heterogeneity that is present with these studies, right, where not all these studies were looking at the same intervention. They were not looking at the same outcomes. As we've kind of highlighted in multiple different ways, there's a lot of variability just that these observational studies were looking at. So, or they had. Whenever you include, I think, certain questions about inclusion of studies for a systematic review like this is you want to make sure that the inclusion are, patients that that they're certainly interested in, right? They're looking at ocular myasthenic patients. They're looking at adults. And they used specific exclusion criteria too. They had specific methods of extraction, which I think were all sound. And I also want to mention, was there a possibility of publication bias? And we kind of touched on this from some of the things we talked about with the variability, and there certainly could be. Once again, just highlighting that you want to try to, by using the methods that they use, or at least when you're including these studies, you want to try to avoid risk of bias or including studies with risk of bias into a systematic review.
The main clinical question here was, what is the proportion of patients with ocular myasthenia who go on to convert to secondary generalized myasthenia? And then of those patients, are there certain risk factors for conversion to secondary generalized myasthenia gravis that could be identified? So this table or graph is really looking at that first question, the proportion of patients with ocular myasthenia who convert to secondary generalized myasthenia. And here they have all 31 studies sort of listed on top of each other with the overall proportion of patients that convert to secondary generalized myasthenia. And you can see there's quite a range in the proportion of patients who convert from study to study. And I think this graph is just a nice way to just visually glance at that. This diamond at the bottom is sort of the overall proportion of patients who convert, and that happens to be right around sort of the center line there. And you can note just sort of the heterogeneity that they had to grapple with in this study again between each of these different studies.
Yeah, and by kind of doing the eyeball test as you mentioned and looking closely, when you look at the confidence intervals, right, amongst all the studies that were involved, you see that there wasn't much overlap. Sure, some of them did overlap, but there was a lot on either side of the spectrum, as you can see, just kind of looking at all the confidence intervals as well. And at the bottom they included the I squared, which looking for the percent of variability in the effect estimates due to heterogeneity, and certainly that number was 95.86%, which it's high.
Right. And just to kind of state it out loud for maybe people who aren't as familiar with statistics, because us in clinical practice aren't necessarily thinking about statistics all the time, the I squared really closer to 0 is less heterogeneity, and then closer to 100% is more heterogeneity. And so this I squared, like you mentioned, is quite high, around 95%. And just to put some other numbers there, their total pooled proportion of patients who did generalize from ocular to secondary generalized myasthenia was 39%, with a range of 11% to 84%. That confidence interval was 32% to 47%, again limited by the I squared value at 95%.
Yeah, I mean, they also applied the grade working group grades of evidence in this case and felt that the certainty was very low for that finding. Not only that, but there are other findings too. There are other outcomes that they looked at, like the relative risk of female sex for secondary generalization of myasthenia gravis and the relative risk of acetylcholine receptor antibody positivity for secondary generalized myasthenia gravis, where while the confidence interval did not cross 1 for acetylcholine receptor antibody positivity, the certainty for that finding was low.
Right. I did actually appreciate that this paper did sort of just use descriptive words to try to assess the certainty of each pooled assessment. Like you mentioned, the risk ratio of converting if you're acetylcholine positive or acetylcholine negative, and sort of what's the certainty, because there's a risk of converting in terms of percentage, but then how certain are we about that number? And I think this paper did a nice job of highlighting that given the heterogeneity, it's a little bit harder to be certain about those numbers that are just averages from all the papers. I think there are two, they go through in the paper a lot of risk factors for potentially converting to generalized myasthenia, including sex, investigations such as acetylcholine antibody status, MuSK antibody status, single fiber EMG and repetitive nerve stimulation, and thymic imaging, so whether somebody has thymic hyperplasia or thymoma. And then they sort of descriptively pooled people into European and non-European / Asian descent to see if there was a difference in risk there. age, and then presenting factors in terms of diplopia, ptosis, or both. And so they kind of do a lot of descriptions for most of those categories, given that it was hard to do subgroup analyses given the heterogeneity for each group. They do give a pooled risk ratio for sex and acetylcholine antibody status, which I can highlight. So for sex, really in general, there was no effect on risk of conversion to generalized myasthenia. All studies did report on the sex of their patients, and the pooled risk ratio was 1.06 with a confidence interval of 0.96 to 1.17, so crossed 1, like you mentioned. And then in terms of acetylcholine antibody receptor status, there was a risk ratio of 1.3 with a confidence interval of 1.05 to 1.56. So as you mentioned, that one did not cross 1. So perhaps mildly skewed towards acetylcholine antibody receptor positivity, increasing the risk for generalization, but with very low certainty, as you mentioned. And the overall proportion of patients who generalized with the acetylcholine antibody receptor positivity was 37% versus 39% overall, so essentially equivalent. Then kind of going through the others, they did some descriptions. Not all the studies reported on single fiber EMG, for example, or presenting factors, but they kind of walk us through and describe each of these in the papers that did report them. So for example, presenting factors, there were 4 papers that commented on this, and each one was sort of different in terms of, one I think mentioned diplopia had a higher risk of generalization. Another mentioned ptosis was a higher risk of generalization. And then another one was both diplopia and ptosis together would have a higher risk of generalization. And so walking through each of the other sort of subcategories, there was really no agreement between papers in terms of, for example, whether thymic hyperplasia and thymoma increase your risk, or whether having a positive single fiber EMG increases your risk. And in particular, I think things like single fiber EMG are so dependent on what muscles you're testing, depending on the symptoms, operator dependent, whether they've been treated with immunosuppression or not at that point. That was another question. Does immunosuppression or being on immunosuppressant medications affect your risk of generalizing? And 6 studies showed a lower risk of generalization with immunosuppression, but 7 studies showed no effect of immunosuppression on generalization.
Yeah, and they included us in their supplementary material too, a table with interventions and treatments, and just looking at that list, there's a wide variety of medications. I mean, obviously symptomatic treatment with pyridostigmine, but also your immunosuppressions, corticosteroids, azathioprine, mycophenolate, cyclosporin, tacrolimus, IVIG. So a whole kind of lot of variability between the studies and the interventions they use. So, overall, looking at all the kind of secondary outcomes, many of them, there was just, there was a lot of kind of discrepancy with smaller amounts of studies showing, one thing, and other sets of studies showing something else. It's hard to kind of draw from that, from each of those factors that they looked at, really, especially considering that, these studies were observational studies.
Does this information kind of change our clinical practice in terms of how we're screening people with ocular myasthenia gravis, or how we're counseling patients with ocular myasthenia about their risk of generalization? I don't know if you have any thoughts on that.
Yeah, I think that it's, in this case, I think it's challenging or at least I don't think that this would change my practice, my clinical practice. I think in terms of one of the goals of the systematic review, we're definitely right to look at risk factors in our own clinical practice and try to see, is someone more likely to develop secondary generalized myasthenia gravis than someone else? And that's a question that's been around for a long time. And there's been a lot of speculation, a lot of kind of different results from observational studies, as we've seen in this systematic review. Certainly that way we can identify those patients, are there ways to reduce that risk, especially with interventions? because we want to reduce the burden of patients developing secondary generalized myasthenia gravis. But ultimately, the systematic review doesn't really, at least because there was so much heterogeneity in the studies, the fact that the studies were observational, so certainly they're at more likely risk of having bias, and because of that, it's hard to kind of, at least I don't see that kind of affecting my practice right now. I think if anything, it definitely tells us that more studies need to be done. One thing I would be curious about is why was there heterogeneity in the studies? There wasn't any mention of a subgroup analysis or meta regression being done to kind of look into that. I certainly think we could have some suspicions. Whether it's from a methodological standpoint or whether these studies were looking at different outcomes, certainly different populations, different risks. So we can have kind of suspicions, but that's something that I would be certainly interested in knowing is why was there so much heterogeneity in the study, in the systematic review that was done.
Right. Yeah, definitely. I agree. I just wanted to echo your point about the need for more studies. I think the fact that this paper was able to find 31 studies to be able to answer this question, and only one was prospective, was pretty limiting in terms of the heterogeneity, because they weren't controlling for things. Many of these studies weren't prospective, sort of controlled trials, rather looking back at data that had already been collected. And so I think it really does highlight the need for a prospective trial or trials to answer this question. And I think sort of in terms of next steps or additional questions, one thing patients want to know is not just is their risk of generalizing, but also sort of one thing I find myself talking to patients a lot about is over what period of time can we feel more certain that they'll stay ocular versus are they still at risk of generalizing if they've had ocular only symptoms for 1 year, 5 years, 10 years. And so I think a prospective trial, not only about like risks of generalization, but also about time course for people who do generalize could be really helpful in the clinic in terms of like the questions patients are asking when we are diagnosing them with ocular myasthenia.
Yeah, and those are kind of great questions, and certainly questions that I've had patients ask me, and I certainly can't give any definitive answers. But ultimately, I think that when I see a patient with myasthenia for the first time, especially if it's shortened after a diagnosis or I make the diagnosis, their symptoms, are, especially if they're primarily ocular. I have found that some patients, their livelihood, right, their jobs are very much reliable on their ocular symptoms, or at least treatment of their ocular symptoms. And I find that in those patients, they're going to be more on board with being a little bit more aggressive and possibly using immunosuppression in those patients. Whereas, some patients will get benefit with pyridostigmine, some don't. I don't find diplopia to be responsive to pyridostigmine. Sometimes if it's more ptosis that patients have, then that can be more responsive, but it also depends on the patient's situation, and then having an in-depth conversation with them regarding these treatment options. I have found that is something that I've been doing and I will continue to do, and I think we'll always have those conversations with patients. But certainly patients are interested in what's the risk of developing secondary generalization? When, as you mentioned, Savannah, when will that happen? We certainly have a general sense that usually within the first several years after onset, that's kind of the highest risk, and that as time goes on, that risk decreases. But I have seen patients where they develop secondary generalization of their myasthenia gravis years after the onset of their symptoms.
Right. And I think there's something, of course, we're always counseling patients about risk of myasthenic crisis or flares and when to go to the emergency room. But I do find that my ocular patients in general find a lot of comfort when they've only had ocular symptoms in not having to worry about that quite as much. And so if we had a little bit of data to tell people, maybe just to ease their mind after a certain period of time that their risk of generalizing might not be zero, but might be quite low, I think that would be a nice way to be able to counsel patients that we just don't have yet at this point in time. But like you said, I think in general, just telling them that the risk seems to go down the longer their symptoms are just affecting their eyes, I think that's kind of still helpful in what we have for now.
Yeah. Another thing to take into account as well, I mean, just looking at other kind of implications for clinicians and kind of limitations is, asking the question about, these studies are all of these risk factors that, patients really care about? Are there other risk factors also that for them, they care about as well too? That's certainly hard because a lot of these studies were done at different times in different countries, and, you know, once again, gets back to the methodology of how the study was done. There was a lot of variability there, but certainly that's other things to kind of also keep in mind as well when developing these studies. Um, certainly, additional questions with newer medications that have been coming out the last several years and then on the horizon is, what are the roles of those medications in this circumstance? Is there any role for those medications? Those are, unanswered questions at this time, and time will tell.
Right. And I think, like you said, having conversations about benefits and risks of treating at all, if people are having, for example, just ptosis, that's not overly bothersome to them. But if we knew that, for example, immunosuppression would potentially reduce their risk of generalization, that might be a big factor in the equation of whether or not to treat people
Yep.
early and aggressively. Because, prednisone and a lot of our immunosuppressants do have side effects, sort of to be determined on maybe some of the newer infusion medications, although certainly they have side effects too.
Yeah, absolutely.
So I think there are a lot of, this article I think was really helpful in putting some numbers to it, just limited by the observational nature of the studies that are out there. But I think additional studies, maybe more prospective research, would be really helpful to answer some of these questions.
Yeah. Yeah, and I think certainly, databases, registries, large registries that have been, used for many years and even decades, I think could be helpful as well too, that track patients over time, and, that look at a lot of different, everything from risk factors to, when do they develop secondary generalization, what symptoms do they have, what immunosuppression that they're on. Those are helpful to track patients as well. I think, having that information will be helpful in this circumstance moving forward. So it was great to talk with you today and to spend the time kind of reviewing this article that, something that we deal with on a daily basis and seeing our patients with myasthenia gravis. And so we'll go ahead and conclude. Thanks so much for your time, and take care.